Hello, everybody. I'm back with the fifth lecture on cognitive behavior therapy in the developing countries. And now to shift the gears a bit, next couple of lectures are going to be on good history taking. And I'm not going to talk specifically about history taking, but I'm just going to highlight a few important aspects of it. And the point is that we want to do as thorough and as comprehensive and as meaningful assessment of a patient based on the format, on the criteria, diagnostic criteria that we follow. And I know that in developing countries that the time reserved for the first encounter with the patient is quite low. It's quite less, in fact. Like it's in the Western countries, usually for a psychiatric or psychological assessment, it is about 60 minutes for an uncomplicated assessment. But in the developing countries that I know of, 2-3 countries, people do the initial assessment in 30 minutes or less. It is important that we do a thorough initial assessment. So today I'm going to talk about the why part of mental health interview or mental health assessment. Now, I'm a psychosomatic medicine specialist, so my initial assessment, and I was a geriatric psychiatrist as well. So depending upon the patient I'm seeing, the assessment would vary a bit, but the assessments can vary dramatically between professionals, because as a medical doctor, I had to ask a lot of medical information about the medicines, information about previous treatments, and those sort of things. But a psychologist doesn't need to ask that much information in terms of the medical information. Similarly, if it's a nurse, she may be basically doing an interview to assess risk for safety, or she might be involved in some type of crisis intervention interview. So her assessment will be different. So there are the interview can differ between professionals, and you have to, because my knowledge is mostly as a psychiatrist, and I've seen psychological assessments as well. So that's where I'm going to mostly be talking about. Now, any type of clinical assessment basically can be divided into three elements. So one is the what of the assessment, and what of the assessment is basically what you are expected to ask. And we get a lot of training on that during our clinical training period. So medical students will get a lot of training on what they have to ask. So they will really become experts in that they have to cover these 10 headings and these 20 subheadings for a good assessment. I'm not going to talk about the what part of the clinical interview, because again, as I said in the previous slide, my assessment will not be what you may be doing. So your what may be different than my what. But then the interview also has a why part, where we have to understand why we are asking what we are asking. And even when a doctor graduates after completing medical school, many of them are not really sure why they are asking what they are asking in an interview. They are very good at knowing what they are supposed to ask, but they can't connect that what with why. They can't connect the significance of what they're asking. So it takes another few years before they start realizing that what they ask has a real significance. And the third element is how. So the how part is that how you ask what you ask. Even though you know what you are supposed to ask, you can't really have a patient interview like someone sitting in front of you and filling out a form. You can't do that way. And you will get challenging patients who will be very focused on certain topics, and they won't be ready to move on to other topics. So you have to figure out the how part. So this talk is going to be briefly about the why part, and next talk will be about the how part. This is a cut and paste from a website that's PsychDB website. So if you type in the web address is given on this slide. I would encourage you to subscribe to this website. It is primarily for psychiatrists, but it has a lot of relevant material for clinical psychologists and other mental health professionals as well. It is free to join, and you will find tons of information on this website. It is run by professionals, and they monitor, they have committees that look to make sure that the information that is being put on it is reliable and it's scientifically valid information. So, as this website puts it, every question you ask should have a purpose. And while young graduates know what to ask, they don't necessarily know the purpose. And that's the why part. So once you know why you are asking that question, you would know the purpose of that question. I'm going to talk about 8 or 9 major headings that almost all mental health professionals cover to variable extent. So depending upon their specific training or specific field of clinical practice, they may go into greater details in certain areas and less detail in other areas. But they almost all ask the same type of, they all cover these what areas. And I'm going to highlight the why aspect of this what. So, of course, when you start with an introduction, you get some basic demographic information. And the why is why you do it. There are 2 important aspects to it. First, it creates a natural introductory interaction because you're meeting for the first time. So you want to introduce to each other. So you being the provider, there's a good chance that the person already knows your name, but you still can introduce your name and you can tell that you are going to assess. And you don't have to spend 5 minutes telling the patient about yourself. But then you take some time to learn the basic information about the patient. So it gets the interview started, and it also provides the demographic information that will be required for record keeping purposes, and as well as for you to put that basic demographic into perspective when you are asking questions. Because interview with a 15-year-old will be different from a 40-year-old and one from 70-year-old. So with regards to presenting complaints, even though you want to write down presenting complaints as why the person is coming, it's basically you want to have a thorough or comprehensive idea about what is bothering the patient. And you want to evaluate, so the why you want to do all that, why you want to get all the necessary information is because you want to evaluate those presenting complaints against defined criteria. And if you don't know the defined criteria, you basically may be practicing at a level of a generalist, as somebody, like I discussed in the last talk, that there are a lot of alternative healers who don't necessarily follow any criteria. They do non-specific type of work. So if you're assessing somebody for depression and you don't know what are the criteria for depression or what are types of depression and what are specific criteria for those types of depression, then you are basically in the dark. So you and I will have at least one or maybe a couple of talks on DSM-5 and how DSM-5 is developed, and ICD psychiatry part is developed in a similar manner. So coming back to the why part of presenting complaints and how you gather history around it, is that you're trying to get as much information as possible that you can put it against the criteria, against the diagnostic criteria. You also are assessing for safety and self-risk. And so that's why you ask plenty of questions. So if you were going to ask about if some person presents with depression and he says, I'm depressed, you don't just say, okay, he's saying he's depressed, so it means he's depressed. You need to now make a diagnosis. So that's where you have to ask about sleep, you have to ask about appetite, you ask about energy level, you ask about how significant is depression, are there any suicidal thoughts with it. So that's the why part, that you are basically matching symptoms with the criteria. The past medical history or past mental health history, psychiatric history, mental health history, is the extension of that presenting complaints. You want to assess what is happening with the patient now. Has it happened to him before as well? Or did he suffer other type of mental health issues in the past as well? Again, you're gathering all this information to fit in with the criteria that you should know you're matching against. So if someone presents with depression, for example, you're asking about the past history, and now you start asking about symptoms of mania or hypomania, because if the person has a past history of manic or hypomanic episodes, you cannot diagnose that person simply with major depressive disorder. You will probably have to diagnose with a bipolar disorder and the current episode being a depressive episode. Or if the person has a history of recurrent depression and most of it links with when he's actively abusing drugs to a certain extent in a certain way, then you may be dealing with a situation of substance-induced mood disorder. So that's where the past history and substance abuse history all get connected together, and that's why you ask all this information. Medical history, as for psychiatrists, of course, and for general practitioners, they have to go through it in detail. But for even non-medical practitioners, it is important to ask about medical history for a couple of reasons. And one is because you want to understand the psychosomatic connection. The way psychiatric illnesses or psychiatric symptoms cause physical symptoms, like if someone has anxiety disorder, they can have upset stomach, bowel disorder, movement, headaches, they can have fatigue, so they can have dizziness. So similarly, physical illnesses are connected with mental health illnesses. So someone who is obese has a higher risk of depression. Someone with a coronary heart disease has a higher risk of depression. So there are certain medications that can cause side effects, that can cause psychiatric symptoms. There are medications that can interfere with sleep. So you need to know that information. And even if you are not a prescriber, you have to have some understanding of it, so that if you have concerns about it, you can write. Don't tell the patient. You write to the person who is prescribing those drugs and say that that you have noted that the person is drowsy and he is on some medications that can make him drowsy and it's interfering with his ability to function during the day. Is it something, will you be kindly look into this? So if you are not a prescriber, if you don't have a degree, you can't tell the patient to change that medication. But you can always write to the person who is prescribing that medication. Family history becomes important because you have to understand it addresses the why of the genetic burden and the nature of the psychopathology. So genetic burden is if someone has a family history of depression and now he's depressed as well, or she's depressed as well, that means there is some genetic burden that is contributing to it. But if someone doesn't have family history of depression in immediate family members or even in extended family members, but the person is now depressed and there are previous stresses, then probably that person's prognosis is better and he's probably just dealing with a stressful or distress related situation and hopefully he'll recover from it. But it doesn't mean that he doesn't have major depression that does not require medication. Similarly, you have to understand the nature of psychopathology. And it's if someone has a family history of, say, schizophrenia, and now this person is presenting with depression, then you have to keep in mind, you have to just be watchful about whether this person has had a history that may point towards some type of depression with psychosis or schizoaffective disorder. So you have to, that's why you ask about family history. Similarly, if someone has a family history of suicide and this person is presenting with depression, you have to be extra careful because now you have somebody who has a genetic burden of suicide as well. So that's why you ask about family history. Developmental and social history is basically to get a comprehensive idea about the individual. So you want to get a good idea about how the upbringing was, how the schooling was, how the person did in schooling in terms of performance, behavior, interest in academics, interest in sports during school. So all these are helping you to get an idea about the person and his personality traits or her personality traits. Then you want to get an idea about, if it's an adult, you want to get an idea about their job history, occupation history, their family history, their lifestyle, their sports system, their coping style, their stresses, and all this is going to help you to put together a psychotherapy formulation, and you will have a good idea about the person's personality traits, and you'll get an idea about what sort of therapy will suit that person. So that's the why part of getting developmental and social history. Finally, mental status examination is something that starts happening the moment the person walks into your office. So you observe the patient as the person walks into your office, and throughout the interview, you observe as well as you ask specific questions so that you can get a comprehensive idea about what we call as psychiatric phenomenology, or you can get the idea about the psychomotor symptoms, about the behavior, about affect, about cognition, about thought processes, orientation, about memory, about their level of intelligence. And that's why you do a mental status examination. Most of the mental status examination gets covered as you talk with the patient. You don't have to ask specifically, again, about to fill in the mental status part of your write-up. And that's where the how part comes in, that you conduct your interview in a manner that you gather the information in that is similar to each other instead of in groups that you have to write it down. And that will be the topic of the next presentation. This presentation ends here, and as I always say, if you have not watched the previous presentations, I encourage you to watch them to maintain the continuity. It will help you understand better, and also to share these talks with your friends and other health professionals who you think will benefit from them. These talks are specifically focused at people in the developing countries, and a lot of what I've put together It is discussed at the medical school level in the developing countries, but it's get addressed in the developed countries. But in the developing countries, usually that it doesn't get covered that well. So that's why before I get to discussion on cognitive behavior therapy specifically, I want to discuss a few clinical assessment and diagnostic criteria and those important topics. Thank you very much. Bye.